I can tell you that just about everyone here, especially females, are predisposed to some kind of arthritis, most specifically rheumatoid arthritis, which is the inflammation of a joint resulting because of a mistaken attack by your autoimmune system. Over 50 million American adults have arthritis, making it the #1 cause of disability in the country. This is nearly 4 times as many as the 14 million Americans diagnosed with some type of cancer. Despite its pervasiveness, arthritis doesn't see nearly as many deaths as cancer. Why? Because it can be readily mitigated through orthopedic surgery. This opportunity to cure numerous amounts of people from physically debilitating diseases and abnormalities has captivated me into the field of orthopedic surgery. A quote which has led me through this year in ISM comes from Jim Rohn, which states, "We must all suffer from one of 2 pains, the pain of discipline or the pain of regret. The difference is discipline weighs ounces while regret weighs tons." People tell me that pursuing a career in orthopedic surgery is arduous and takes a lot of commitment, and that is true. You must complete 4 years of college, you must complete 4 years of medical school, 5 years of an accredited graduate medical education, orthopedic residency, and then practice outside of orthopedic residency. Despite this handful of tasks you must complete, imagine how much you would regret it if you were to quit halfway or not even attempt this journey. Losing the once-in-a-lifetime opportunity to do something you're passionate about is far more painful than the amount of time you must put into training for the career. My name is Kenneth OW. I'm a senior at Frisco High. I have 2 siblings. I was in orchestra 9th grade and all through middle school, and HOSA octathlon. And outside of school, I enjoy playing tennis, basketball, and running. My first entry into my independent study was through the research assessments. In my first research assessment, I wanted to understand the many devices used in orthopedic surgery. So I came across an article highlighting patient-specific templating and haptic response devices. Patient-specific templates give us an accurate estimate as to what size of implants should be created, so it's unique to each individual. It also creates accurate drilling and cutting guides, which can help the surgeon during the actual operation. It has been very useful in reducing operation times and costs and the amount of equipment needed. However, it does have its limits when creating templates below bone that's below cartilage, because MRIs and X-rays can't see that kind of bone. So this is where the haptic devices come in, and what they basically do is restrict the surgeon's movement if they move outside of the guide that was generated by the patient-specific template. And this can this reduces the invasiveness of the procedure and risks of anything going wrong. And they use infrared light to guide the surgeon through the operation. My second research assessment, I just wanted to know about total knee arthroplasty or total knee replacement. So I came across an article in the database that kind of just gave me an intro to what this is and how it works. Total knee arthroplasty is just used to describe injuries in the femur, tibia, and patella, like the whole part of the knee. It doesn't always have to be used as a whole. If you have an injury in part of your knee, then you don't need a whole total knee arthroplasty. And it is used to treat older people with osteoarthritis or rheumatoid arthritis. There has been a recent trend in the younger generation, so our generation, because since we're more involved in athletic activities, it creates wear and tear in the knee, and more people our age are seen getting this treatment, even though it's not supposed to be for people our age. This procedure involves replacing the damaged part of the knee with a prosthesis, which is made of metal and on polyethylene. Infection is very common and can be countered by prescription of antibiotics. And this procedure has been pretty successful. These are the numbers that go to say how successful it is. It has a 90% success rate after 10 years, and then 80 after 20. And even if if the prosthesis fails or loosens, because you're going to be in physical activities every day, so it might be prone to loosening. If that happens, then it's an easy fix, and it can just prolong the life of it even longer. And this is just a picture of before and after. It's just an artificial total knee arthroplasty. My third research assessment underscored the controversial topic of residency hours. There's a case with a woman named Libby Zion who died as a result of care under patients who were fatigued. These were just residency patients, so it wasn't intentional. But these people, since residency students are constantly working, they can be fatigued, and unfortunately, this woman died under their supervision. As a result, they passed the Libby Zion law, which was just in New York, but eventually, it was an 80-hour regulation just in New York, but eventually it passed universally, like across the U.S. There's been like a controversy through this regulation because, according to most orthopedic surgeons, there's an estimated 10,000 hours of required instruction to be an expert in the field, and that's just beginning before like you actually get into the career. So this regulation kind of cuts off from that, and many residency students may have to take extra years, which can be more costly to achieve more experience in the field. Going on to the next assessment, I noticed that there was a huge increase in ACL tears in people our age, and I just wanted to know why this is caused and what orthopedic surgeons have been doing to reduce this. There's a statistic stating that there has been a 400% increase, so that's a really huge increase compared to about 20 years ago. And this again is due to sports, but menisci tears are just as prominent as ACL tears, even more. And surgeons aren't able to, for people under the age of 10 or younger kids that have these injuries, surgeons are making them postpone the operation until 2 years or even 3 years because their bone hasn't fully formed in the knee. And this has led to, there was a girl mentioned in this article that she had a ligament in her knee torn, and they postponed it 2 years later, but during that time she had to wait for the surgery. She injured it even more, and that pain has been seen 10 years later still in her knee. So the question is, do you operate on a child that's like 10 years old and hopefully not injure any of the bone that's developing in their knee, or do you tell them to wear a brace, wait 10 years or wait 2 years and hopefully not injure the knee? These are some of the questions doctors might assess, but at the end of the day, it's up to the patient to decide whether or not he or she wants to go with the procedure. And also, ACL tears and menisci tears are more frequent in females because if you can see on the diagram on the right, the little arch inside the knee is called a knee notch or intercondylar notch. And basically in women, they're just born with it more defined, and this makes them more susceptible to these injuries. My final assessment, after seeing a common problem of cartilage damage and restoration of the cartilage, which was mentioned by one of my mentors, or one of the guys I interviewed named Dr. Schwartz, he said that restoring the cartilage was the most, well, in his opinion, the most common problem in orthopedic surgery. So I decided to research ways that, or advancements orthopedic surgeons have made in trying to fix this problem. So collagen is a structural protein found in muscles, tendons, and the skin, and it's essential for the formation of joints and muscles. This article specifically discussed osteochondrial lesions of the talus. Osteochondrial just means cartilage and bone, and these lesions usually happen after repeated ankle sprains. The collagen paste being described in the article, basically it's stem cells that are harvested from the patient himself, and harvesting these collagen stem cells allow for the surgeon to create a 3D hyaline cartilage scaffold, which is hyaline is just one of the 3 types of cartilages, and this has been successful in restoring movement in the talus region and people beginning to resume running, things like that. And this procedure is not as surgically intensive as traditional talus osteochondral repairs, and it's less costly as well. This hasn't been implemented into actual practice because this is just research in a lab, but hopefully 10 years along the line, during our time, this might be a thing. On the bottom left, it just shows an x-ray of the bones in the feet, and on the top right, that's just an MRI of an osteochondrial lesion in the talus area. Another part of my ISM year was conducting interviews. My first interviewee was Dr. Sean Haslam. He's a surgeon over at Centennial Medical Center, and he specializes in hip and knee arthroplasty. After the interview, I came out with a greater knowledge because I wanted to originally, I didn't really understand the whole cemented and uncemented joint replacement thing and how that works. And basically he said that it depends on what region of the world you're in. So if you're in the US, they will use a non-cemented approach, but anywhere else you'd use cemented. And the only reason you use cemented for sure is if the patient has severe arthritis or is overweight. He also said that during your residency that you should move to cities because they have a higher infection rate, so you get to see more of these cases, because in the long run, when you're actually operating, your knowledge on operation is far more greater than your knowledge on just the topic and book knowledge. And most surgeons know what they're good at and what they aren't. So a lot of surgeons may refer to other surgeons if they're not that much of an expert in a specific area, because orthopedic surgery can range in so many different specialties. My second interview was with Dr. Adam Starr. He is a pelvic fracture specialist at UT Southwestern. What I found pretty interesting is that he co-invented a device called a star frame, which is, it serves as it kind of holds the pieces of bone together when he's doing, when he's treating fractures in the hip region or parts of the hip, and this device is able to hold pieces of bone in place while he's doing arthroscopies, which is a more minimally invasive procedure. During the interview, he emphasized that orthopedics are the career in general. It takes up a huge part of your life, and that you can't just force your way into the field. And outside of operations, he conducts research, because he told me that every few years or so, your knowledge on what you think is going to be, it's always changing, and the field is always updated with information. My third interview was with Dr. OW. He's a primary care sports medicine physician at UT Southwestern. He isn't directly an orthopedic surgeon, but he works very closely with them, and he uses non-surgical procedures to treat injuries. He used to actually work with the Cleveland Cavaliers as their primary care physician. Now he's the Dallas Stars. He's with the Dallas Stars. A piece of advice I took out of his interview is that you should take more classes that will make you a more well-rounded person during college. So foreign language is really beneficial in the field, because patients are always coming in from diverse backgrounds, and medical residencies actually look for people that are fluent in other languages as well. My fourth interview was with Dr. Schwartz. He's a knee, hip, and shoulder specialist, and he uses arthroscopy, which is a minimally invasive procedure to treat problems in the knee, hip, and shoulder. He told me to come in with an open-minded approach into medicine, because since the field is so vast, you are prone to find out that what your orthopedic surgery or what you're interested in initially might change, and you might like something else even better. He also brought up the problem of the government intervention in hospitals, and basically the government requires him to follow their set of rules to treat patients and to communicate with patients. So he's actually my mentor, so during my mentor visits, he has to manually type in information of the patient rather than actually tell them, and this kind of removes the traditional doctor-patient communication that we all used to like. He also said that the hardest part, or his biggest challenge in becoming an orthopedic surgeon, was gaining self-confidence, because during residency he's always working with a staff that's supervising him. So making that huge leap into actually operating alone and making the calls by himself was a huge challenge. My final interview was with Dr. Royer. He was actually referenced to me by an ISM student, and he's a foot and ankle orthopedic surgeon, or foot and ankle specialist. And I came in with questions about the osteochondral lesions that I mentioned earlier, and he was able to answer them, and he emailed me a PowerPoint he had of patients that he's treated with these osteochondral lesions. So I thought that was pretty helpful and friendly on his side. And he went with me over the specialty selection, how that works. And a key advice he gave me is that you have to be able to think on your feet for the job, because especially in foot and ankle, the patients come so frequently. He has to see about 20 to 30 patients a day, and you have to be able to know what's wrong with them and quickly analyze the situation. He also said that it doesn't matter what you major in during your undergrad or during college. It's just, you should just go with what you feel like learning. So for my original work, I researched, because during all my interviews I found out that blood clotting was a pretty big problem, especially after total knee and total hip arthroplasties. So I decided to create a research paper over deep venous thrombosis and the ways to fix it. And basically what DVT is a blood clot that is caused because during surgery, since wherever they're operating on you, the wound is open for a prolonged period of time. The blood doesn't know whether it's just a normal wound, and so it just sends out a lot of platelets to stop the clotting or to clot the area. But since your wound is open for a long period of time during surgery, these clots may build up in major blood vessels, and that's what deep venous thrombosis is, which is blood clots in major blood vessels. And while this isn't initially, it's not harmful, I mean, it's not deadly, but it can lead to something called pulmonary embolism, which it is deadly. It's basically these blood clots in the vessels travel up to the lung area, and that can cause difficulty in breathing and other serious issues as well. And like I said, it's fatal. So I decided to make it's kind of a guide that for people that are about to go into surgery of the total knee or hip replacement surgeries, so they know exactly what kind of devices orthopedic surgeons may tell them to use after the operation to prevent this issue. These are the 3 devices that I kind of researched and compared all 3 of them using statistical data taken from control groups. On the top left, that's an IPC or intermittent compression device, and basically it compresses the calf area, and that stimulates the blood flow in that area, so it can prevent the risk of blood clotting. On the top right is graduated compression stocking. A lot of people wear this nowadays if they have like varicose veins and things, and this also helps with preventing blood clots because it also stimulates blood flow in the leg area. And on the bottom, that's a venous foot pump, and basically it mimics the movement of actually walking by putting weight on the foot, and that can also stimulate blood flow. So during my mentor visits, that was another huge part of my year in ISM. So far, I haven't been able to sit in on any surgeries, but I still picked up a lot of useful information about what goes on inside the field. First of all, it is important for the orthopedic surgeon to pay close attention to the patient's description of the problem, because actually in one of the cases I was watching, there's an old guy he was about 80 years old, that just walked in and said, "Oh, there's pain on my knee, and it happens when I'm just bending or climbing stairs." And that's kind of a vague description, like how long has it been happening, or is there specific times when it's not happening? He never said any of that, but just those 2 key pieces of information led Dr. Schwartz to easily diagnose him with patellofemoral arthritis. So basically he conducted a series of diagnostic tests on the guy to test the range of movement in his knee. And he felt for different pressure points and spots where the patient was sensitive to pain. And that's how he was able to come to identify the small pieces of evidence of patellofemoral arthritis. Also, communication with the patient is important. So like after the patient visit, going back to the government regulation thing, even though he has to enter in information on the computer, then send that to his secretary, which will then who will then send it out to the patient, he's still communicating with the patient, because the patient needs to know what's wrong with them and the updated status of their operation or their condition. So patient communication is also a huge part of the field. And at the end of the day, it's still the patient's decision on whether or not they want, let's say, to have a steroid shot in their knee, or to actually partake in a whole total knee or total knee arthroplasty, or total knee arthroplasty operation. So while there's rapid changes in the field due to different government regulations, orthopedic surgery is still a fun and challenging and satisfying career at the end. And I want to leave you guys with another quote by Jim Rohn, which says, "Discipline is the bridge between goals and accomplishment." And that's just my blog, and thank you.